All right, Jason, can you hear me? Yeah, I can see okay, but I can't hear you on your. I can hear you through through the WhatsApp, but no, I'm on. I cannot hear you in Zoom. Yes, co-host.
Emma?
Yeah, I can hear now. Can you hear me now?
Hi, perfect.
Yes, I can hear now.
Good morning to Julio, if you can hear us. Julio Mauricio Tagovega. Let me just check. Can you hear us now?
Yes. Yeah.
Yeah. Thanks, Dr. Bennett.
Can you, yes. Hello, I can't hear you. I can't hear now.
Can you hear us now?
Yes.
Yeah, it's because we're closing the microphones when we're not speaking for the conference.
Okay, I need to see that you can change the screens okay. I want
Okay,
to.
let me do that real quick as
Yeah,
the
okay,
other people are working on something else.
okay.
Did you see that, Dr. Bennett?
Yeah, I can hear you. What are you saying now?
I made one of the cameras spotlight, and I was changing it,
Oh,
so
no, it
that works
hasn't
too.
changed. It's the same screen. And I want to make sure, I want to see how you do it. I want to see how you change the screen.
Okay, let me call you because, just let me call you.
Okay. Okay. Yeah, okay. I got you on WhatsApp. Oh, really? So I should, they can see me? Come on, my camera's not even on. Oh, my microphone. Okay. Yeah, I can turn that off.
Okay. Thank you. Okay. I see that still screen clearing. We can go around. Just because I'm so sorry. Can someone else handle something? Oh, I'm sorry then.
Uriel, can you hear me?
Yes, Doc. Good morning.
Good morning. How you doing?
Pretty fine, Doc. I'm in the Congress.
You aware?
I'm in the Congress. I'm watching it.
Yeah, yeah, okay, yeah, yeah. They're gonna get some people in here.
I will try, but because here it's like
Oh,
1 a.m.
hold on, I think, okay, let me mute myself, okay.
I will make the promo, but I think in the team, in the students team.
I can't talk, Uriel, you'll have to text, okay?
Okay, no worry, don't worry. I will go. Doctor, can you make me a panelist for texting you, please?
Funny, I'm trying to get you in, but I don't seem to be able to. Okay, you're in now, right?
Ahora las variables I'm not sure I'm going to so
Screen, like, can we make it black for just a minute or so? Is there a remote control where we can? Yeah. Βρήκε το μικροφωνίζει, έκανε κάτι άκουσε το μικροφωνίζει.
Ναι, εντάξει, δεν είναι εγώ εδώ να το ρυθμίσω, βέβαια. Το θέμα είναι πρόγραμμα. Ένα πρόγραμμα. Το έχω εγώ.
Πρόγραμμα, ωραία. Αν θέλετε να σας πω για να πω, δηλαδή, να έχουμε κάτι, θα φέρω την τσάντα μου, να υπάρχει το ράδιο μου εδώ. Πάνω τώρα.
Θέλω το χαρτί είναι το έχεις από το πράγμα θα το μισθοποιήσεις. Το σου χαρτί είναι το έχεις. Εντάξει, εντάξει.
Does the piano player know any boogie woogie?
Ψήφισε.
Μπορείς στην κάμερα να μετακινήσεις λίγο το πόδι του. Α, αυτή είναι. Ωραία.
Οπότε βάζω αγράφο. Οκ. Βάζω αγράφο.
Βασικά στη σωστή είμαστε. Ωραία.
Τις αγράφεις.
Ποιο να γράφω.
Το τι είναι αγράφο. Δεν το πάρω.
It is. It's there, but we just want to fix everything. And after the workshop, we're gonna have or maybe after the break. So, after the break.
Okay. That's wonderful.
Okay. Actually, do you know if Dr. Ben is recording this?
Now, click camera. Το συντάξουμε, δεν πειράζει. Υπάρχει το αρχείο. Για αυτό μπορεί να μην...
Yeah, I think so.
Are you sure? Everything's set.
Seems that way.
Tell me if we have. Yeah.
Let's
You
see.
know what? I don't want to know.
I mean,
No.
eh,
Just let
eh.
me finish one part on stage.
Of course. Don't worry about
Is
it.
it too much?
No, it's chill for now.
No, let's go.
Θα το διαπάνω σε αυτό. Πάνω.
Έψαχνα περισσότερο να δω πώς
Είναι πώς είναι στη μιλάει,
Ναι. Πάμε στο τέλος.
Στο ίντερνετ υπάρχει. Δεν είναι αριθμό και έχουν συγκρίνει στους
Έχεις
κλειούς.
απόλυτο δίκιο.
Right, good morning, everyone. I'll welcome you to beautiful Crete, certainly one of the coolest islands in the world. My name is Ibrahim Efe, and I just want to make a little start. I want to tell you about what we were thinking when we first set out the vision for this conference. So we wanted to do it a little bit differently, knowing that the majority of the audience will be composed of medical students. So we're thinking of doing something that is a little less academic and of pure informational nature, but rather inspiring, thought-provoking. I think that is what we as students really need to know when we want to make our final decision to enter a career in neurosurgery. So if you have the chance to look at the program booklet, you'll probably see a lot of recurring motives. I think the word future comes up quite a couple of times. So we will, for example, look at the future of spine surgery and the role that technology will play. We will have a boundless New Horizons session, which will close the conference tomorrow, where we will have a particular look at what our master neurosurgeons are spending their time trying to push the boundaries of neurosurgical practice in their everyday life. Other things that we want to focus on are things where we really want to foster debate, stimulate debate between you all when it comes to things like gender equity, right, where we still have this huge gender gap in neurosurgery. For this, we have invited a very well accomplished female neurosurgeon from Pakistan, Dr. Anila Darbar, for example. Unfortunately, she couldn't make it here, but she will participate virtually to speak about the things that she has accomplished and what gender equity in neurosurgery really means to her. And there are a lot of things where we thought that our students really need to be need to know how to look at neurosurgery from different perspectives. We will, in a bit, hear about how to really deal with complications, for example. I mean, we as medical students, we do have our perfectionist tendencies at times. I think that just comes from nature. So we're all afraid of making mistakes. And Professor Mehmet Zilali, for example, will speak about how to deal with making mistakes and how to cope with this, how to improve every single day. Of course, I like to always think in three-step or three-point plans. So I try to think of three main advice that I want to give you, or especially the medical students, of course. Number one would be, as I said, we want this to be rather a forum to think and to discuss rather than just an academic scientific program. But obviously, when you look back at this conference in a year from now, you will probably have forgotten a lot of things that were mentioned here. That's completely fine. But one major advice that I can give you is to really pinpoint a major, like a main aspect that each of our master neurosurgeons have shared with us today. Because these are the things that will always stick in mind, where even in years from now, you will think back and say, okay, yeah, Professor Meyer mentioned this and that during his lecture in Crete. Number two would be, the most important thing about a conference is certainly making connections, networking. And it's so beautiful to see a full hall. It's the first time that I see a hall full like this since the beginning of the pandemic. So I think this is the best opportunity for all of us to build friendships, to build connections that will be long lasting. Also, of course, I want you all to really make use of the fact that we have some of the most famous neurosurgeons around. So obviously in the coffee breaks or even after the scientific program, do feel encouraged to speak to our professors and really learn how they view, how they look back to their careers. Maybe you have a few personal questions that you want to ask them. Feel free to do that. I'm very sure their professors would be glad to answer those questions. And number three is, I'm trying to think of number three spontaneously, but I think the one thing that we should really try to do is, the conference does not end with the end of the scientific program tonight, right? So we will have a lot of different things that we want to do together after, this late afternoon, this evening, a soccer tournament. There's going to be the Dandy Olympiad. There's going to be a Sunday trip where we want to explore Hania town and Lake Kurnas. And I think this is definitely a good opportunity for all of us to get together. So I really appreciate to be able to stand here. When I'm in charge of doing something, it always starts with a delay. But I hope we'll just cope with the time. Now, I would like to introduce Vice Mayor of Hania, Dr. Mr. Nikolaos Hazirakis, on the stage. Mr. Hazirakis, please.
Thank you very much. Good morning to everyone. It is with a great pleasure that I'm in this wonderful hotel today to welcome here in Hania the beginning of the first medical student World Congress of Neurosurgery. Through such supranational events like this one that starts today, we have the opportunity to give you a glimpse of our hometown Hania, a city of many tales that left its print through the centuries of geographical, historical, and cultural reasons. Our ambition for our city is to restore its place as a center of culture, arts, scientists, and sports. This ambition is implemented in addition to the other efforts and by hosting important events such as this conference. Understanding the activity of a healthy and alert brain is a vital focus of scientific research. In this respect, making progress in the field of neurosurgery is one of the most important global challenges of our time, with a lot of questions still remaining. Without any other delay, I would like to welcome you to Hania and to wish to all of you to have an enjoyable stay. I will be glad to hear your findings and conclusions about your innovative and valuable research at this meeting. Thank you very much. Welcome to Hania.
Thanks a lot for your warm welcome, Mr. Azarakis. Next up, I would like to call Mariana to the stage. She is our annual meeting chair, and she has been in charge of organizing all the logistics of this conference. She had a lot of weight on her shoulders, but she did a great job. Mariana, please.
Ladies and gentlemen, I would like to welcome you to our Congress and to my beautiful homeland, Crete. It is a great pleasure and honor for me to be here among so many future doctors and great personalities who are leaders of the neurosurgical field. I would like to welcome you by narrating you some facts of Greek history, as well as introducing you to some historical Greek personalities who have pushed themselves to their limits and were undoubtedly boundless thinkers. As you can see in the first picture, there is a skull where you can see one hole in it. This skull has been found in Crete. According to many archaeologists, this is the first neurosurgical procedure ever and is estimated around 3000 BC. The scientists that investigated this skull supported that this could not have been done by accident or by natural causes. So they concluded that this skull has been strategically perforated. Perhaps it is not a coincidence that we are here in Greece for our first student congress in neurosurgery, where neurosurgery may have been invented. There are many examples of boundless thinkers in the ancient and modern history of Greece, and you can find them in any field: history, politics, science, art, literature, and sports. You might have heard of Alexander the Great, who is in the second picture. This man, by the age of 30, had created one of the largest empires in history, stretching from Greece to northwestern India. The ancient Greeks did also establish the Olympic Games and the theater, as we all know them today. One more leader from modern history is the politician from Hania, Eleftherios Venizelos, who was an expert on foreign politics and international relations. From the field of medicine, I would like to introduce you to two great doctors, George Papanikolaou and Amelia Fleming. In the 1920s, George Papanikolaou invented the Papanikolaou test, abbreviated as PAP test and also known as Pap smear, which is a method of cervical screening used to detect potentially precancerous and cancerous processes in the cervix. This test has helped all women in the world to deter cervical cancer. Amelia Fleming, who was the wife of Alexander Fleming, managed to distinguish herself among many scientists, but also served as a member of parliament, became the president of the Association of Greek Women Scientists, and fought for human rights and justice between men and women. From the field of literature, I would like to mention three prominent people: Nikos Kazantzakis, Odysseus Litis, and George Seferis. All of them have been proposed for the Nobel Prize, but only Odysseus Solitis and George Seferis were finally nominated. Of course, there are many examples of global leaders and boundless thinkers, but I just wanted to introduce you to some of them who are Greeks, and perhaps you didn't have the chance to hear them before. I wish you all a pleasant attendance. I'm sure that you will enjoy your time here and that you will want to come back to Greece again. I would also like to personally thank every single member of organizing committees for the collaboration that we have had all this time, and I hope to have the opportunity to work with them again in the future. Last but not least, I would like to especially thank Professor Salim Abdulrauf, who has placed his trust in me for this event. Thank you all for your time, for coming, and wish you enjoy this Congress.
Thank you very much, Mariana, for this excursion into Greek history. We'll see a lot more of that tomorrow morning. Now I would like to welcome Dilara on the stage. She's our scientific program chair. To open the first scientific session of the conference, the keynote session featuring Professor Mehmet Zilali from Izmir and Professor Bernard Meyer from Munich. Please, Dilara.
Thank you very much, Ibrahim. Yeah, please, we'd like to welcome Professor Mehmet Zilali on stage. We wanted to start off our conference with world-renowned speakers from around the world who are experts in their fields. Professor Mehmet Zilali and Professor Bernard Meyer, they're experts in spine surgery. Professor Mehmet Zilali came all the way from Izmir, Turkey. He's a spine surgeon and the founder of the first fellowship program of spine surgery in Turkey that has fellows both nationally and internationally. He's also the president of the Middle East Spine Society and the president of the Asian Pacific Spine Society. Professor Zilali, the stage is yours.
Thanks a lot. It's my great pleasure to be with very young colleagues, and the future of neurosurgery, I think, will come from you. Can I take this in the middle part? Okay. My talk will, my presentation order will be in this order. I will. Thank you. Short CV, then the complication avoidance in spine surgery. Then I will mention the learning from mistakes, and we'll try to make some outlines about the future of spine surgery and neurosurgery and art, a very unique subject probably. How do I define myself? It's interesting, it has turned. Physician, neuroscientist, surgeon, or amateur artist. Maybe it fits for this slide. I'm from Izmir. Izmir is the third big city of Turkey with 3.5 million population. A very mild city, easy to live, very modernized, according to some others, not hectic like Istanbul. I was the resident in Ege University Neurosurgery Department in 1980 to 86. This is me. My first mentor was Erdem Tunçbay. She passed away. He was graduated from Chicago Western University and get a board certification from US and has founded Ege University Neurosurgery Department in 1966. One of the pioneering neurosurgeons in Turkey. I had the opportunity to go to Kopf Klinikum, Erlangen, I know Bernard Mayer was also there. It was with Professor Schramm and Farbush. I did some research studies on spinal cord injury and intra-operative monitoring, electrophysiologic monitoring. These are some friends. This is Dr. Romstöck, Dr. Taniguchi, and Professor Schramm, who has retired. And then my third mentor probably is Edward Benzel. I met him in 1999, and I've been with him for some periods. And when I was back from that, I started to found the spine section of Turkish Neurosurgery Society in 1995, and we organized courses, and we tried to implement modern spine surgery in neurosurgery. Actually, before that time, neurosurgery was lacking with instrumentation and stabilization of the spine. These are advanced spine courses. We did 2 cadaver spine courses together with Ed Benzel, and we pursued them with the advanced spine courses. This year we will make it the 20th course. And we are also progressing with the Istanbul Spine Masters. This next year will be 6th course. As my moderator mentioned, nowadays I'm serving as chairman of the WFS Spine Committee. And what about complication avoidance in spine surgery? There are many topics to present in this, but I will just give some examples from those. The most common complication is probably the dural tear and CSF leakage and pedicle screw malpositioning. I will, not most common probably, but I will just give some examples from those. Dural tears incidence has been reported between 1 to 15%. We believe that they are underreported in the literature because the surgeon does not write that he or she has lacerated the dura during surgery to the report, and then we cannot know that. There are instances where it most commonly happens, and in the disc surgery, in the experienced hands, it is quite uncommon. Not experienced hand is more common. And in the minimally invasive surgery, it's in the startup period, in the learning period, it's more common. Clinical findings may be CSF leakage, headache, meningocele, and nerve root injury. If dural tears causes CSF leakage, then complications may happen. One of the most important complications is infection. More uncommon complication is pseudomeningocele and intracranial hypotension, acute subdural hematoma, and tonsil herniation. It's very uncommon, but it may happen. This is one example of pseudomeningocele after a dural tear of hemilaminectomy at L5 level. If it doesn't cause any symptom, we can just leave it, just observe it. How to avoid and repair them? It's a common sense that we have to try to repair it if we see that. And primary repair, if it is not very possible, we can cover it with grafts, fat, muscle, fascia, blood patch, and gel foam. There are recently many tissue sealants and fibrin glue and synthetic membranes to repair the dural tears. Dural repair during tubular retractor, it's a very often used minimally invasive spine surgery tool. We use tubes and make small incisions, and it may be difficult to repair the dura, to make stitches on the dura. So needle driver and laparoscopic nut pusher may be used to facilitate our stitches. Fat grafts may also have advantages. However, if you push it too much, root compression and fibrosis inside the graft may happen. In the beginning, we ask the patients bed rest, wound closure with prolonged stitches, external lumbar drainage we can apply, rate removal of wound drains, and revision surgery we can do. This is a series from our department with 9% CSF leakages, but most of them are complex spine surgery. These are the site of approach, type of approach, instrumentation. With instrumentation, it is more common. Without instrumentation, it's less common. And these are the location and of surgery and CSF leakage. And we have done, in total, 11 lumbar drainage, late removal of wound drains 26, and revision surgery in 5 patients only. Yes, I can skip those. And as I said before, retrospective articles underestimate complication incidence, but it's been reported between 1 to 15%. What about the pedicle screw complication? Actually, to avoid pedicle screw malpositioning, there are many techniques. One is that you must use very often the AP and lateral fluoroscopy. The other one is the navigation, CT-guided navigation or fluoroscope navigation. Another one is the EMG monitoring during pedicle screw insertion. But screw malpositioning has been reported between 1.2 to 28%. How to avoid? More training on anatomy is necessary. Meticulous technique, sufficient exposition, bony landmarks must be identified, identification of intact pedicle with key wire probe and EMG, AP and lateral view by C-arm and navigation, intraoperative CT scans. There are also intraoperative CT scan possibilities. How to treat early revision may require, especially such a screw position. The screw is passing through the middle of the canal, so then according to the level, it injures the spinal cord or cauda equina. If it is on the lateral part, it may not cause any nerve problem, but it then causes a weak stabilization. So because the screw is not inside the bone, and it is a weak construct. So if it enters outside the vertebral body, anterior to the vertebral body, long screw, then it may injure the great vessels like aorta or vena cava. Again, more training and experience are necessary to avoid some such complications. However, we must tell that experienced surgeon is the surgeon who has done many mistakes and who have learned from their mistakes. So it is sometimes a frustrating event during the surgery or after surgery. You notice that you have done some complication or a mistake. So this is our baseline knowledge, goes with raw data, basic science application, and clinical applications,
and it continues to learn. So then experience adds and your understanding the techniques, surgical techniques, and patient selection criteria develops by the time with your experience. How can we learn from mistakes? Probably first we must mention the complication and mistake are something different. However, this difference is not very certain. There are instances that we cannot differentiate a complication from a mistake. So sometimes patient may sue you and then that problem cannot be differentiated from the other. I like to classify the mistakes in spine surgery as mistakes of indication, approach, stabilization, and complication management. I will give you some examples and the reasons of those complications or mistakes. This is after trauma, fall from height in 2002, who had a long fixation because of fracture dislocation, but after a while, both rods have been broken. But if you see that there is no screw at T10 and T11, and the anterior strut is weak. So we made a reoperation, a revision surgery, made a longer fixation, and placed an anterior graft. As you know, our pedicle screws are posterior fixation devices, and if there is not good anterior strut, they can fail. This is from biomechanical concepts of momentum is force plus distance. So if we have, this is the reasons of screw loosening and the reasons of screw breakage. However, if we support anterior column, such a breakage may not happen. So biomechanical concepts we must learn to apply some spinal surgery in our practice. Mistakes of complication management. This case had a previous anterior plating and screw fixation, but after a while the surgeon has seen this film. One of the two screws has backed out, but one of them is about 50% backed out. So he proposed to follow the patient.
Professor Zilli, I'm very sorry to interrupt. We have 5 minutes left. 5 minutes,
yeah. Okay. But after a while, the patient came with this film. One of the screws is lacking. So the screw has been lost. Probably has penetrated esophagus and went down to digestive system. So we removed all the system and we saw the esophagus was ruptured and we repaired the esophagus. So what are the reasons of mistakes? Lack of knowledge, insufficient training, surgery without sufficient technical conditions, accepting new techniques or implants without consideration of evidence. And we must improve our training with postgraduate courses, fellowship programs, be cautious to company-supported courses, collaboration with general surgery and thoracic surgery. Anterior approach may be easier and more effective than posterior approach to some extent. And in general saying, patient evaluation is more important than learning surgical techniques. And in conclusion, To make less mistakes, we must discuss more and choose proper indications. Instruments are a tool, not an aim. Achieving a good vision is the aim of surgery. I will give some, do I have some time for spine surgical disciplines?
Yes.
As you know, there is a big competition between neurosurgery and orthopedic surgery on spine. But there are also medical disciplines like physical therapy, rheumatology, and pain therapy. Most of the spinal disorders patients come to you with non-specific symptoms, low back pain or neck pain. 85 to 90% of patients are those. And specific spinal disorders, probably 10 to 15% of whole population you see. So origins of the low back pain are various. And in one patient, you can have more than one origins of the pain. So the main issue is that operate the patient, not the films, must be our logo. Technical improvements are allowed. We will see in other lectures today that with the normal, I will show you one example. The instrumentation is very useful in some instances like this. Actually, normal aging is a kyphotic development. We can turn it back probably, but it's not that much easy. So, for instance, this case, this lady had a cervicothoracic kyphosis. We had a two-stage surgery, first on thoracic and then cervical spine with multiple osteotomies, and we could achieve a position like this. It is possible. So geriatric spine surgery possible, but with good selection and good planning. The compression fusion and mobility preservation is probably the future. Open surgeries are turning out to do minimally invasive surgeries. However, patient examinations are lacking in our general practice, and imaging evaluation is resulting with incidental pathologies, operation of the films. Less implants, more implants, and economic burden to the societies. And I will show you these two slides. More minimally invasive surgery in the future, more biotechnology and science, fusion enhancers and others, better outcome analysis in the future. These are future expectations, positive expectations. However, there are negatives. Insufficient patient evaluation, surgery for incidental image findings, unnecessary implants, effect of industry, increased costs, insufficient outcome analysis, and longer training period, and more unqualified surgeons. I can finish here. I can leave the others. Okay.
Thank you very much, Professor Zilali, for your beautiful presentation. We're honored to have had the chance to hear your advices and have a look at your patients. We'll have questions with Professor Zilali after we have Professor Meyer. Professor Meyer has come all the way, Bernhard Meyer has come all the way from Munich, Germany. He's also a spine surgeon. He's the chair of neurosurgery, the neurosurgery department, and the director of the neurosurgical clinic at the Technical University in Munich. And he was also the chairperson of the Education and Fellowship Committee of Eurospine. When you're ready, Professor, the stage is yours.
Being a Mac user, it's hard to add. This is the presentation mode, right? Yeah.
Perfect.
Well, thank you very much for having me here. It's it's a new concept, but I'm happy to be here and give a talk. I hope it's a talk that you understand. Usually I talk in front of doctors, so it's new to talk in front of students. I should tell you something about the role of technology in spine surgery. And I will start out by showing you a problematic issue. This is Scott Sparello. Mr. Scott was a doctor from the UK, and what it shows you in a more or less funny way is that many technologies, especially in spine surgery, fail. Actually, more technologies that are brought in will fail than will survive. And it's always the same. There's initial hype, and then it goes down, and after several years, nobody knows what has been the case and why it has been used. So I start my talk by giving you some guidance on how to use technology, according to me, not to repeat the same mistakes that we have made 25 or 20 years ago. And then I will show you in the second stage of how to use it in a concept, in a clinical framework, a concept, so it makes sense. And in the end, I will pick out one specific technology and I'll show you the state of the art today, and I will show you pretty much what you will see in the next 20 years when you will become neurosurgeons and are inclined to do so. So it's always a problem of people to adopt a new technology. You have people on one end of the spectrum who are very eager and are so-called early adopters, but then on the other hand you have people who will never adopt a new technology because they're skeptic. So in life it tends to be truth lies in the middle. It depends also where you work. If you work in an academic center with a high volume with highly complex cases, or if you work in a center which is a community hospital or private hospital, low volume and low complexity, you have to have a technology that makes it simple and not difficult, and you have to do it often, not in a special case. This is Occam's razor. I don't know if you know who Occam was. It was a philosopher and told you the principle is keep it simple. It's more complicated philosophy, but the principle is keep it simple, otherwise it will fail. So if you look at it from people who never adopt to people who will be rapid adopters, then you will have to have a technology that has a very low complexity for the one who uses it. It should also have a low cost, otherwise there will be doubts in how much money would I invest, and it should be done in high volumes. So if you put that together, my advice would be you have a technology that should clearly serve a clinical purpose or a need. Not technology comes first and you think, what am I going to do with it? And it's the best if you have it in a clinical framework, and I'll show you an example right after this. It should always make your work more efficient and improve the outcome. Be it incremental, be it a very small step, but it should improve. What it should not, and that has been one of the mistakes in the past, distract you from the actual task of work. Working in the brain or spine is complex enough. If someone gives you a technology that makes it even more difficult because your attention is distracted from it, then it's not good. Don't even think about using it. It should never be used as a gadget, which was the number one mistake for many of these things that have failed, be it artificial disc, be it whatever. There has been a hype. It has been used to attract patients, lure patients into your practice, and that will always fail. And you should always think, how much money do I invest for something which has a small benefit? Okay? So I start with, according to me, is a classical example. You have a clinical need in a clinical concept, and then you use the technology for the benefit of the patient. Spinal oncology is that. On your left-hand side, you see a curve. You don't have to look at it. It's just an example of what is happening in oncology in general. This is for non-small cell lung cancer. This has been a death sentence a couple of years ago. For many, many patients nowadays, this has become a chronic disease. Some forms of cancers in my country have been declared a curable disease by major health insurances. So you have to change your mindset. In another field, in oncology, something has happened which has made things completely different. Cancer is not a death sentence. Cancer has become, in the majority of patients, a chronic disease, just like chronic renal failure, etc., etc. So you have to adapt your concept to that. As a spine surgeon, you will see heaps of patients with metastasis in their spine. This is from our recent publication. It summarizes over 1,000 surgeries and our concept that we have adapted. The number one problem, if you look at the small picture in there, is that the standard of how patients were treated by open surgery with instrumentation, with traditional titanium or chrome cobalt things, has a problem. In cancer patients, up to 30% will develop a wound problem later on in the course because of their adjuvant therapy or their radiotherapy. Now, wound problem is not a minor problem for a cancer patient, because if a cancer patient develops a wound problem, then you interrupt that thing that keeps him alive, which is his targeted therapy, his chemotherapy, or his local control therapy with radiotherapy. So having a wound problem or not makes a difference if you live or you don't live for a cancer patient, okay? So in this instance, this is where minimally invasive spine surgery has the most value, because it reduces your wound problems. To do so, you need navigation, so you have always your construct in place and don't need revision surgeries. Plus, we also adapted something which is new, cement-augmented screws, because with minimally invasive, you don't have a fusion, but you need a stable contract for over many years. And the latest thing we adopted was radiolucent implant things. I just go through that very quickly. If you use navigation, you reduce, instead of using fluoroscopy or x-rays during surgery, you reduce the radiation exposure of yourself and the patient by the factor of 10. You reduce the rate of patients you have to revise after surgery by half. This is also true for cervical spine and not only for lumbar spine. The only thing that you have to invest is time and energy initially. That means it takes you about 9 months in a major center like mine, where many people are trained and you have a lot of people running around, technicians and OR nurses, until you come back to your normal times. That means you have to use that technology every day, several times. Otherwise, it will fail. For example, the other thing, new technology, radiolucent materials. It gives you a better perioperative complication rate, you have a better oncological follow-up, and you have better radiation planning and execution. This is an MR with instrumentation in place, as if you had nothing in there. If you compare that to an MR post-operatively with a titanium screw where you don't see anything, that makes a big difference. And this makes also a difference if you go a step further. Radiation planning, if you don't see anything, will always be that you have tiny doses over several times, and you include more volume in that. If you see afterwards, if you use a radiolucent material, you can have higher doses for a better local control because your volume is less. So we would treat per default, the patient with a metastasis like that in a navigated anterior-posterior surgery, one-stop shop. Patient lies 45 degrees. You put in pedicle screws from the back through stab incisions with navigation, and without the patient turning around, you do a minimally invasive thoracotomy like that and do a vertebral body replacement. It takes about 2 hours and it's all done. That's the result. So I hope I could give you an idea of when it makes sense to use new technologies in a concept like spine tumor surgery concept. It reduces your wound problems by 5. It reduces your revision rates by half using navigation and cement augmentation. It allows for a very early adjuvant therapy, be it radiotherapy or other. It allows for innovative radiation concept to enhance that local control, and it keeps your patient up and running. That means independent through all stages. So this is a context where technology and adopting it makes sense. Now I pick out one, which I've been talking about, image guidance and robotics in spine surgery, and show you the evolution. Well, it all started many years ago when you had 3D imaging available in the OR, and it developed over these years. And in my department today, we have 3D fluoroscopy navigation 3 times. We have a proper CT navigation. We have intraoperative robotics, which is the third. I will show you that. So this is my presence. It might be the future for others, but this is the presence and the state of art that I have. We're adding to that now augmented reality, which has been fumbled around a little bit. And this is the newest development that I did with this. Which is a camera and a decoder, and then you can use any tablet. You don't need big things, big screens or whatever, because everything you have is in the glasses. I think I can show you that. These were the first surgeries that we did. So you see me looking not on the screen of that tablet behind me, but I see exactly what is there in my glasses, and I can look at what I'm doing. I don't have to look at any screen. I have that. What you see on the right-hand side is what I see in my glasses, overlapping what I do. Obviously, that makes a difference, because then everything is very mean. So it's quite clear nowadays that spinal navigation improves your surgery, increases your accuracy, reduces your revision rate, reduces the radiation exposure, especially if you don't see the anatomy, if you use MIS. But it leaves room for improvement. You see figures here, they are very good, but the German saying goes that the better is the enemy of the good. So you're always trying to be better than that, and that the question is, or was, can robots help you with that? In principle they could, because they have no fatigue, they never tremble, and they can repeat infinitely the same thing without getting tired with the same precision. You cannot do that. So to bridge that gap is the problem that you have nowadays. So the number one, you can't read what I have been writing there, the number one reason for making mistakes or having a screw not placed properly with navigation is never the machine. It's always the surgeon. And I can show you on that picture why. I'm holding a drill guide, looking at the screen, and then I need the drill. If with my left hand I'm grabbing the drill, the line of sight is broken. And I will shift that drill guide only a bit, but enough to have the wrong trajectory. If I look back, I still have the same trajectory on the screen, and I will use the obviously wrong trajectory for that. This is because I'm not a robot. I can do several things together, like moving my left arm without being completely stable with my right arm, etc. So this is where a robot nowadays helps, no less, no more. There are 4 robots on the market that you can buy for spinal surgery. This up in the left-hand corner is the development with which it all started. I show you. It's a Massot technology, which is now bought by Medtronic, a major competitor on the market, and has several developments. Now it's a huge machine, as you can see. It's the same huge machine as the Excelsius from Globus, and then the other one here, the Rosa, and the smaller one from BrainLab. The three that they see, they're up to $1 million each, okay? Depending on where you live. I started using robots in 2007. This is the first robot. It's an actuator, looks like a Coke can. You give him the navigational position, you bring him near the field, and then he will guide the arm of your drill guide exactly in the position. You just have to use a drill and go in and out, and then you have the correct thing. It wasn't quite as easy because there were many things that were not really good. So we had 2 publications very early out, and we didn't adopt the technology at that time because we said it has too many flaws. Actually, this thing is not different from the tiny thing you just saw. It just looks that way. And this is sold to you as a revolution in spine surgery. It's not. It's light years away from being a revolution. This is a very, very expensive holder of your drill guide. No less, no more. Nothing else happens.
Professor Meyer, I'm very sorry to interrupt. You have 5 minutes left.
How many minutes?
5 minutes.
5 minutes, that's good. I show you this with the circ, that's the arm that we have. Because of that picture, I can't see where I am. See, his arm is there. You bring it in position, and it simply holds where you are. You can have an actuator in front of it that gives you a tiny guidance, but that's it. No less, no more, okay? And the others are just bigger, but do the same. So the question is that really a revolution? No, it's certainly not. And you know why? Because this is the future. Look at it. That's an industrial robot. This is a balloon, he has a needle on it, okay? And this is what he can do. See? This is actually available, this thing. Now, same here, I don't know if you can see it right. This thing exerts the same pressure exactly millions of times. This is a thing that you can do because he can feel and he has haptics. No robots today in medicine have haptics, okay? So this is an industrial robot. In industries, this is already state of the art. Fully automatic in a workflow. You see the same arm that I showed you. It's something that will be present when you will be probably spine surgeons in 10 years. It should be simple. This is a very simple concept how to do that. So you don't need any expert knowledge. It should be intuitive, okay? So you need tactile robots, and they need to be soft. Soft means they adapt to what you do. And the next step that is already present and that we are doing is that they learn. And I hope this is the last video that I can show. I have the privilege to work with a very good group of people. So this is learning to self. On the left-hand side, you see a child of the age of 4 learning to hold a weight or learning to open a door with a key. And on the left-hand side, you see the same robot arm learning that. Or this is something they did with, I think, people from their home base. They did several tasks, and every time the robot beats the human being. So this is the future, and this is what the future would look like when you will be probably 20 years down the line. But in the next 5 years, the first thing that you will see is probably a robot in spine surgery that acts a little bit like you had seen in the first video, that has a haptic feedback, but you still need to control it yourself. And then step by step, it will take another 7 years or so because of the major safety issues. It will have semi-automatic features. And the thing that you just saw, doing it completely by itself, like constructing an automobile, will probably be 25 years to 30 years down the line. Good, thank you very much.
Thank you, Professor Meyer, for a wonderful presentation and taking us into the future of spine surgery. We'll just have one question from Professor Abduraouf, and then we'll go into coffee break.
Watching this presentation, saying, you know what, I want to become a spine surgeon. I want to become a really exceptional spine surgeon. The question is, why should I go through pain and learn how to do shunt operations in children, learn to do what I do, complex open surgery, 12-hour surgery, and this surgery, when I need to be doing this and learn it really well? Why don't I go and do a residency of 4 or 5 years, become a really exceptional spine surgeon? Why do I need to learn all these things for years that I will never do the rest of my career? Some years ago, as you guys know, I wrote an editorial where I suggested that neurosurgery in the future needs to be subspecialized training rather than training everybody to do everything. And many of my mentors in the generation before were very critical of me writing that editorial. So the question is this: should we have a separate residency for spine surgery and a separate residency for cranial surgery? The data shows that high volume means better outcome for patients. If you do certain things all the time, you have better outcomes for patients. So is it antiquated model, the current training models we have? You go, you spend 6, 7 years training in everything.
Yeah, good question. The same is true for orthopedic surgeons. Actually, they learn how to make the shoulder surgery, knee surgery, hip surgery, trauma, many aspects, and then spine. The issue with us was, since now, the most privileged part of orthopedic discipline is spine surgery, was spine surgery, but for neurosurgery it is not. It is less privileged part. The people wanted to be a good vascular surgeon or skull-based surgeon, such things. But the future is demanding from us that we have to create a specialty of spine surgery or spine specialty. As I mentioned in one of my slides, there are orthopedics, neurosurgeons, rheumatologists, and physical therapists and pain physicians. All are doing many things in spine, and we don't know each other very well. And we are very busy in our residency programs with cranial surgery and also spine surgery. The issue is that there is a market and then general neurosurgeons don't leave that market. Don't want to leave, economic reasons, because although they learn a lot about the cranial surgery, in the practice they do mostly spine. Even my vascular surgeons, if they do private, they do spine. And so this will be more improved by next generation.
Thank you. So what you said about the same thing, if you're a final year medical student, you go into orthopedics to become a spine surgeon, you spend years doing shoulder and limb surgery. Why? So, Professor Mike.
Right, it's happening anyway. So this is something that will be real when you 20 years down the line, there will be the spine surgeon. That's quite clear. But you have to go with a smooth transition, because otherwise society, I mean, be it our societies, neurosurgical societies, be it society of patients, there's too much stress on them. You have to give them time. But exactly what I'm doing. I mean, the last 10 years I've spent to put up programs for Germany, for Europe, and how to be a spine surgeon. So this is all fixed and set. And the transition to having a subspecialization is basically just a year away, if at all, at least in my country and in Europe. So you will have a basic training in neurosurgery, not doing everything, and then you specialize early. The only thing that you have to do then is then to say, well, let's say we're only doing 3 years of basic neurosurgical training or basic orthopedic training, and then you become a spine surgeon. And the content of that should be interdisciplinary, be it orthopedic, be it neurosurgical. There shouldn't be any division between that. And then probably another 10 years down the line, when everything has adapted to the subspecialization, then it's quite obvious. Then there is the specialist, and then everything else will follow. So I think
You're telling me this generation will not get that better. The people graduating next year.
Oh, well, they will have the benefit that they, depending on where you are, I think it's the same in the US than within Europe. I can't speak for Asia. You will have a very special program that gives you all the content, be it that you're a young orthopedic or a young neurosurgical resident. If your focus is on spine, the person who trains you needs to follow that, otherwise he doesn't get any accreditation. So it's quite easy. You get the content, so the political things around that will follow.
Thank you, Professor Mayer. Do we have 1 second? I just want to, we have the next generation of also leaders of spine surgery. Dr. Raul Rincon from Mexico is here. I want to get he's one generation after you. I want to get his input on this question really quickly, Dilara. 1 minute.
Sure.
And I just really want our students to think through these things. So please, go ahead.
Well, that's a very good question. I mean, nowadays, if I turn a little back in my practice, I mean, I love neurosurgery, and that's since I was a kid, I wanted to be a neurosurgeon. However, my practice currently is 99% is spine surgery. So probably if I had the chance, or like if I had this view, particularly like a specific spine surgery specialty, more defined, probably would be like the best way to go if you get just into it for the next 6-7 years probably. Probably the same years as a neurosurgery, and with the subspecialty, probably like the formal spine surgery program, but then like a subspecialty like pediatric spine surgery, like something more like that. So probably would be a good idea, but I don't know. I mean, it's as Dr. Mayer said, it's a lot of things, political things also, so administrative, but hopefully in the future.
Thank you, Raul. Thank you, Dilara. Appreciate it.
Thank you very much. We'll be having a 10-minute coffee break and then we'll have you back here again. Thank you very much.
Hello, Jason, can you hear?
Yeah, sure. Let me check something real quick. Okay, so we have very specific. So yeah. Okay, just waiting for the wireless. Mouse. Let's go ahead and add whatever.
Brauchst du deine Präsentation?
Nein, ich wollte ihn auf den Laptop ziehen.
So.
Ja, das muss ich machen, der ist ein bisschen kaputt. Ich muss festhalten.
Das brauchen wir nicht.
Ja. Nein, danach.
Das heißt, das ist.
Nicolosis.
συνεχίστε να μιλάτε απλά. We just go on. We're just checking the microphone. Great. Oh, ευχαριστώ. Okay, οπότε τώρα πρέπει να φτιάξουμε το πρόβλημα του ήχου ότι δεν ακούγεται το PC. Ακούγεται. Παίζουν βίντεο τώρα και δεν ακούμε κάτι. Oh, maybe.
these are the microphones we selected to be heard. And let's not change that.
And you know how to get this off. Yeah, we're starting in 30 seconds, I would say. Yeah, başlayacağız şimdi. Okay, I'm just gonna start. Exactly, yeah. All right, I'll welcome you all back. One of the words that I'm probably going to use most frequently over the course of the next 2 days is the word boundless. Under the theme of the conference, Boundless Thinking, we decided to dedicate 2 lectures to this motto specifically. So we will have the Boundless Ingenuity lecture today and the Boundless Diversity lecture tomorrow. Boundless Ingenuity is really dedicated to surgical innovation and outside-the-box thinking. And we've invited one of the best speakers to talk about this topic. Unfortunately, he could not make it to Crete. He will give us his talk virtually. And Yonut, our representative from the Scientific Program Committee, please welcome on the stage to introduce Dr. Ayçerian.
The button, okay. Hello, ladies and gentlemen. It is my honor to introduce to you Professor Ayçerian, a school-based expert, a passionate educator, and the founding chairman of the Neurosurgical Department at Krishna Institute of Medical Sciences in Karad, India. He is the Counselor General of the Asian Congress of Neurological Surgeons and a member of WFNS Anatomy Committee. Professor Cherian is the inventor of the basal cysternostomy, a school-based procedure to reduce intracranial pressure in traumatic brain injury. He then went on to introduce a theory on CSF circulation and its cooling and cleaning effects on the brain, on the brain parenchyma. Thank you. Now I would like to introduce Professor Cherian. Professor, you may proceed.
Yes. Can you hear me?
Yes.
Okay.
Yes.
All right. It's an honor to be talking to all of you. As they say, the child is the father of man. So you guys are the future. And more than speaking in audiences where you have aged and not so flexible minds, it's always good to talk to people whose minds are at least open to some extent. You know, medical education, I believe, destroys a lot of flexibility, but at least before they are professors of neurosurgery, you're still flexible. Now, thank you, Salim. Thank you, Ibrahim, and the organizers for calling me to this. I know Ibrahim for a long time. I'm trying to share my screen. Okay, can you see my screen?
Yes.
Right, great. So you're going to talk about new perspectives in CSF. Now, I was very happy to hear Bernard talking on Franca Amica. We just acquired a Franca Amica, which we have managed to navigate, and it's being used as our endoscope holder. As he said, of course, although I don't do any spine surgery, I agree that robotics are the future. Not probably as a surgeon substitute, but something to help the surgeon at the moment. To be a surgeon substitute, I guess it will take 100 years more at whatever pace we go, because as me and probably Salim would agree, a surgeon is a different beast. So there's a lot of things that a robot has to be able to do to be equating to a surgeon. That aside, we're talking about something different today. 2007, we started something quite accidentally. And that was the micro neurosurgery and opening the basal systems for trauma. Happened quite accidentally. In fact, to tell a long story short, I would say that I mistook a head trauma for an aneurysm. So in aneurysm, you generally, when you have a tight brain, you go to the systems, you open the system, because the aneurysm is in the system. So you have to open the system. There's no way you can get out clipping an aneurysm without opening the systems. So when you open the systems, generally the brain becomes lax. I mistook, I won't tell you how I mistook, it's a long story. But all over the world, wherever there's trauma, in fact, 5/6 of the world has a lot of trauma. And this is a theme I got from one of my fellows. This is a photograph that they were operating. And you can see the brain, the subdural is being evacuated. And in a few minutes, that's what happened. You can see on the right side, the brain's bulging out. And this is called malignant brain edema. And this is one of the most feared things in neurosurgery. You know, it's, we call it samskaras that appears from generations, like fear of snakes, and many communities have different samskaras. So neurosurgical communities fear is this malignant, so-called malignant brain swelling. People say there's nothing we can do about it. So we looked at the scans of these patients. After accidentally we figured that, the brain is swelling out. So we looked at the scans and we found that there's no CSF. The brain was edematous. There was no CSF. So we asked a few guys, a few neurosurgeons, where did all the CSF go? Physics is not the strong point for most neurosurgeons. So they said the CSF got compressed. That's not possible, because if you knew hydraulics, you will know that to compress 100 ml of fluid to almost nothing, you would require the weight of a car, maybe more even. Okay? So it was not possible. So we figured that the CSF was moving somewhere. Where was it moving? Probably to inside the brain. Inside the brain. And is that possible? Because the CSF is in the base of the brain. We think the CSF exists because the brain should be suspended on that CSF. And if you take out the CSF, the brain might deform. This is what our thinking of CSF is about. The conventional thinking of CSF is that the brain is bathed in that. It's like a whale in a sea. So if you beach a whale, the whale's going to die. You see, if God or any power who created or even evolution was the designer for such a brain, I would call him foolish unless he figured some other uses for it. So we started thinking that maybe the CSF is going inside normally as well. And we started working on it, and we figured that all the blood vessels from the system went into the brain. You can see the blood vessels, all the blood vessels are in the systems. That's why aneurysms are in the systems. And all these blood vessels go into the brain. And they arise in the systems. We also figured that the CSF goes around these vessels. They go around these vessels into the brain. And the space that they go around these vessels, they're called Varsha-Robin spaces. They've been known from a long time. So in other words, you have a cistern in the base, and then you have subarachnoid hemorrhage into that cistern. The pressure in the cistern rises, and this CSF is displaced in the brain. And imagine injecting 100 ml to your 1.5 liter Coca-Cola bottle. Imagine injecting, let's say, 100 ml into the Coca-Cola bottle. You know, the pressure will be immense. It will be immense. Exactly what is happening. So there's bleeding into the cisterns. I'll talk about it in the later slides. Now, first thing, whether our theory is right. 2007, we had no evidence. We were just saying that, and you know, at that time I was located in Nepal, and imagine a neurosurgeon from Nepal saying that, and the world community, they laughed. 2012, we had evidence from Harvard. So this is a photograph, a 3D photograph of a vessel, and you can see the cistern continuing all the way around these vessels. It's beautiful. This is exactly what we told people in 2007. And to Salim's credit, I must say, before the evidence came, Salim used to call me for his lectures. Skull-based and vascular faculty, but we used to talk about cystoscopy at least 11, 12 years back with Salim. And that's why he's a visionary. So, I mean, well, it could have been a foolish theory. Nobody was accepting us at that time. But this evidence came later on. And you can see, this is the vessel, my arrow, if you can see, that's the vessel. And around that, you can see the Varsha-Robin spaces. And exactly what's happening. So this is the vessel, and you can see the Varsha-Robin spaces, and these Varsha-Robin spaces are communicating with every part of the brain. So imagine there is a bleeding in here. What happens? That bleeding is a newcomer into the system. It presses the CSF. Now the blood, by virtue of the size of RBC, cannot enter into these Varsha-Robin spaces. Therefore, what happens? What shifts into the Varsha-Robin spaces is the fluid, is the CSF. So, if our theory was right, this whole subarachnoid space would be filled with blood, and the brain parenchyma or this Varsha-Robin spaces would be filled with fluid. So that was our hypothesis. And so if that happened, the current treatment for trauma, severe head trauma, is decompressive hemicraniectomy. So you have an edematous brain, and you open out a large bit of the bone. You allow the brain to swell. It's a 100-year-old surgery. It has got a lot of winning factors. It's a big surgery. I mean, it's a simple, very simple surgery. A trained chimpanzee could do it. I mean, I'm not exaggerating. I see all these trauma surgeons harping around decompressive hemicraniectomy. It's you know, they go to all these conferences and talk about the technique of decompressive hemicraniectomy. I would say milking a cow on my farm would require more technique. if I must say so. And I apologize for it, but that's the truth. So the point is, if you could get into the basal system, if you could get into the basal system in a tight brain and open the systems and let out the CSF, this brain swelling is going to reverse. And that's exactly what we were doing. That's what people are already doing in aneurysm surgeries, and we started doing that for trauma. So then we talked about CSF shift. The articles, obviously, if it's a new concept, big neurosurgical journals are not going to publish it. So we started publishing in small journals. And then from Calgary, we got evidence. So,
Sorry, Professor, you have 3 minutes left.
Okay. So I'm sorry. This is the evidence that we got, and I would say that they put weight onto a weighted block onto a mice brain, and this is what happened, and exactly what we predicted. This the subarachnoid spaces were lined with blood, and there was edema. So CSF shift edema was, we could prove that CSF shift edema was happening. Then
actually does so along very specific.
Then we started wondering, what is the CSF doing inside the brain? So in 3 minutes, I'm going to tell you what CSF does inside the brain. Now we are part of textbook, many chapters, respected journals and all that. But in the beginning, we know how much difficult it was to get this going. But now I'm going to tell you in 1 minute, perhaps, what is the CSF doing inside the brain? Why does the CSF go inside? It is to cool and clean. How does the CSF cool the brain? Using your sinuses. So how does it use your sinuses? When you breathe, the sinuses in your the mucosa in your sinuses, they act like a wet t-shirt. Let's say you're wearing a wet t-shirt, you're wearing a sweaty t-shirt and sitting under a fan, and of course you will humidify the room, but that's not your purpose. Your purpose is to get yourself cooled. So if you sit under a fan, you get cool. Just the same way when you breathe, that's a fan. And your mucosa is the sweaty t-shirt. So it evaporates faster with the air current, cools, and there is evidence right now that this area is 2.5 to 4 degrees cooler. And where is this largest collection of CSF? It is right in the middle of the sinuses. So you can see this is the suprastellar system, and all these sinuses are lined around it. And this cool CSF is pumped into the brain. And what do they use to pump? How is it pumped into the brain? The vascular pulsations. That's the Archimedes screw principle. These vessels pulsate all the way into the brain. And this cool CSF is pumped into the brain. It was a crazy theory when we started off, but now we have a lot of evidence again.
Professor, can you jump to the conclusions, please?
Yes, well, so these are the two things I have gone ahead and I would have liked to go on ahead and talk to you, but 15 minutes is too less. So thank you very much from Karat, and Godspeed.
I just want to say something. What IVE shows is the main concept we want to really, why we have you here as the next generation of neurosurgeons. It doesn't matter where you're sitting in the world, okay? To come up with ideas and concepts. I don't want you to feel like, well, I'm in this small country. You don't have to be in a major center in Germany or the United States for you to come up with a great concept that would change things. IVE, when he did, was think about these things, was in Nepal, okay? So it's not exactly, you don't think of Nepal as a major place in the world where technology or ideas come from, but it's the person, not where you are. Neurosurgery is a baby specialty. So much needs to be done. I want you to believe that you're going to do something that will transform our field. I want you to really believe that. And that is what makes change happen. And IPE is a great example. We're very proud of him. Okay. I heard about him, what he was doing. I invited him to the United States to come and speak. It was great to have him there. So this is what I want you to believe. You know, believe that you can change this very young and baby specialty. IPE, we're very proud of you. Thank you so much.
Thank you, Salim. Thank you very much.
All right, thank you very much, Dr. Cherian. Next up, we will move to our Thinking Beyond the Scalpel session. Thinking Beyond the Scalpel is all about leaving the myth that, you know, if you decide to pursue neurosurgery, you have to give up all the other things. Of course, neurosurgery is certainly a specialty that will keep you up at night, but we have invited two speakers who have other things that are keeping them up at night. So we'll start off with Dr. Federico Nicolosi. He could not make it to Crete, unfortunately, but he sent us our pre-recorded talk, and I'll just ask Dilara, chair of the session, to come help me play this video.
Hello, everyone. Before we start, before I share with you Dr. Federico Nicolosi's video, I would like to introduce him. Dr. Federico Nicolosi is a neurosurgeon. He sent his video from Milan, Italy. He's a neurosurgeon in the Humanities Research Hospital in Milan. He's also a social entrepreneur, so he's going to show us how it's like being a social entrepreneur in the field of neurosurgery in general. He is the founder and CEO of Upsurgeon, a company I believe most of you or maybe all of you are familiar with. Yeah, he's also the lead of the training committee of the Young Neurosurgeons Forum in the WFNS. Without further ado, I would like to start the video with you all. Sorry, everyone. We just need to pause the video because of some technical issues. It's going a little fast. Yeah, so we just to slow it down a bit.
We're trying to speed up the conference a bit, but not like that.
Yeah, we'll take care of that in a second. Sorry. We thank Dr. Federico Nicolosi for taking his time and sending in his video for us. He said, be the change you want to see in the world, and it's nice that he has started something and changing the face of neurosurgery and the way training in it should be. Next, in our session of Thinking Beyond the Scalpel, I would like to introduce our Professor Philippe Schucht. He came from Bern, Switzerland. He's the Deputy Chair of Neurosurgery at the Inselspital University of Bern. And beyond his career as a neurosurgeon, he's going to talk about how is it like to be a global health advocate. He's the perfect definition of that, as he has done many work and advances in changing how neurosurgical care in Myanmar is like. So if you're ready, Professor Schucht, the stage is yours.
Perfect.
Okay, well, thank you very much, Galimera. My name is Philippe Schucht, and I was asked to talk something which we normally don't talk about, and I'm thrilled to do this. I would really like to congratulate the organizers for doing this kind of conference and organizing them on their own, and not only having the usual topics, but kind of thinking beyond what's going to be important for you. My name is Philippe Schucht. I work as a neurosurgeon at university in Switzerland. I'm head of neurosurgical oncology, so I'm a tumor surgeon for adults, for kids, I do neurovascular surgeon. This is what I do 95% of the time. And today I was asked to talk about a few other percentages of my time. I work in Myanmar as well. I work at 2 universities there in Mandalay and in Yangon. And I was asked to share with you why I do this and how we do this, with the idea that maybe some of you thought about doing something like this as well. These are my disclosures. So one is important. I'm going to talk about the work of a foundation which I've created. It's a non-profit foundation. There's also, I'm involved in a different company which helps to do transnational consultation for patients in developing countries. There's no financial impact on this. Why? You're all neurosurgeons. I mean, you're all overachievers, right? I mean, most of you are alpha personalities. You've seen a lot of these teachers. I mean, Abdul Rauf, I think, is like the primary idea of an alpha personality, very high achiever, top of class all the time. This is how many of you are. Why would you want to do something on top of that? That already takes up all of your time. So of course, one reason to do this is because there is a need. There are many countries where the thing that you do in your country is needed. It's not done enough. And the second thing has to do with you. Any kind of publication you read, any blog, any book on happiness, on having a fulfilled life, will have a chapter, and probably one of the main chapters, on meaning and purpose of your life. When we think about what meaning means belonging to or serving something bigger than yourself. And this is one of the sources of happiness and fulfillment you will have in your life. This can be anything. It can be a religious group. It can be your beliefs. It can be your family, your friends, local community. As neurosurgeons, as doctors, it can also mean creating something for others. I would like to show you what we have done But before we do this, if you want to do something like this, and I don't want to make a raise of hands for this, but if you thought you wanted to do something, what are the first steps you have to do? And I think the first thing you have to do is to think about who you are and what you want to do. First question is, what are you good at? If you're not a great teacher, maybe teaching others is not such a great idea. The second thing you have to think of is, what do you like to do? This is absolutely crucial. If you don't really like to do something, you're not going to be really good at, and hence you're going to be poor help for the people you're trying to help. The third thing is, if you want to do this kind of non-profit NGO type of work, think of how you want to do it. Do you want to do it by yourself in a group? Do you want to join the Red Cross or the Médecins Sans Frontières? Or how should engagement look like over the years? And then the last thing is, really think of where you want to do that. And I say this because if you do these kind of projects, and I really engage you to start early doing this kind of work, then you will go there for many years in a row. If you don't like the cold, don't go to Siberia. Go for a place you actually like being. I was at your place 10 years ago. In 2010, I just got my neurosurgeon's degree, and I thought I would like to do something on top or in parallel to my normal career. My idea was I wanted to improve neurosurgical care somewhere. And I thought I would like to do this not by doing the surgery on my own, but my focus was on building local neurosurgical capacity. In other words, helping to create a neurosurgical community in a country. When we first thought about this, and we approached the Red Cross, the Médecins Sans Frontières, we started screening for countries who could use a project like this, and we came up with Myanmar. Myanmar 2011 was a country of 50 million people, so it's the size of Italy or France. It just came out of 50 years of military rule, which was brutal for the country, and they had 4 neurosurgeons. I don't know how many neurosurgeons are in your country, but you do the math. This is more than 10 million patients or people, potential patients, for one neurosurgeon. It was the worst healthcare system, better only than Sierra Leone, which means that countries such as Palestine and Angola were actually much better off than that country. What did we decide to do? And these are the positive takebacks from the time that we've spent the last 10 years in Myanmar. If you want to do something, and what we have done, the first and most important thing is to form a group. You cannot do non-profit on your own. It's much too bothersome. There are too many drawbacks. It's too difficult. Take your friends, like-minded colleagues, form a group. Make a long-term plan. Don't make it a one-year thing for you. Try to think long-term. Make a sustainable long-term plan. Focus on knowledge transfer. Yes, there might be money in your country. Money is never the issue. The one thing that you have, which nobody else has, is knowledge. Share your knowledge. Make this your primary goal. Then, very crucial, try to get a local buy-in. There's no sense in going to a country without the support from the local community, patients, doctors, healthcare officials, all the way down to the politicians. If they're not on your side, any project will invariably fail. And then money, a lot of people have great ideas. They don't do it because they don't have the money. And that's the other way around. Don't do that. Think of how you're going to get funded. But at the beginning, have a great idea. Start having results. Then you get some traction. Then you have something to show up. And then people will fund you to scale your project later on. What have we done? This is the Swiss Neurosurgeons International. We assembled a 10-year program. Our ambition was to train 60 neurosurgeons for this country over a 10-year period. We trained 25 from them in my hospitals. We took them from Myanmar, trained them in Switzerland, and the others were trained on site in Yangon with many other colleagues. There was an American team. There was an English team that helped us do this on the way. We created workshops. We went over there. We had spinal workshops. We had cranial workshops. We had cadaver workshops, always together with the local community. We also went there. So year by year, we would talk to the local community and say, okay, what do you want to learn next year? At the beginning, it was like a herniated disc, then it was meningioma, then it was glioma, all the way to intracranial, to low-grade glioma in the insula. We brought them IOM. They nowadays are capable of doing the same neurosurgery that we have, doing these kind of missions, not where we just go to do surgery, but we make a program together. Then we teach that, we do combined surgery with them. If you're interested in this, there's a publication where we kind of write this stepwise plan that we did over the last 10 years for neurosurgery. Now, as to share with you what failed and what I think is very dangerous for us to do in these countries. The first thing is that whatever you're going to do in these countries, think of the influence you're going to have on these people. If you just go to a country and you do surgery, let's say on a child, and then you go home, what's going to happen to this child? There's very high likelihood it will have an infection or something, and then it's simply going to die. So be very careful about what this patient is going to do the moment you fly back home. Think of the influence of what you're going to have on the local doctors. You're the expert, the world famous neurosurgeon coming in from Italy, coming in from Greece, somewhere. How is the local doctor going to look like if the complicated cases are being done by you? Think of the negative influence that's going to have on the local community and how you can counteract that. Think on the healthcare system. In many countries nowadays, healthcare is being outsourced by the government to NGOs and non-profits because they do this. And that makes, the government spending all their money on military. So think of what kind of an influence you're going to have on the country. I've seen a lot of NGOs and non-profits doing hit and runs, basically parachuting into a country, life-saving surgeries for 2 weeks, and then they're gone. And they have a huge negative impact on all the different states of their society. Please try to avoid that. There are countries now where you can go and they will charge you for doing surgery, right? Many countries where you can go and, a herniated disc is going to be $200, not for the patient to pay, but for you to pay as a doctor so that you can do kind of good karma work. Try to avoid that at all. And secondly, and the third thing is you see when you go to third world countries, you see a lot of secondhand stuff. It's kind of old craniotomy machines, old navigation units. There's a reason we don't want to keep them in our place because they failed, they're broken, they don't really work anymore. Please don't just ship them over. If you want to have them to have great equipment, make sure that this is good equipment that comes with a maintenance program, not just stuff we can't use anymore. And then lastly, and here's a take-back system where you've heard the story about Myanmar. It was freed 10 years ago, and now in February we had a coup. There was a military coup, so the military seized power again, and the first one under attack were the doctors. But now the entire medical community is blacklisted. Most of them, some of them, friends of ours, have been killed. Other ones are persecuted. Most of them have joined the resistance. And I just put this here as a reminder that as gratifying as all this work is, you have to be ready for a bumpy road. There will be crises on end doing this. Good, I would like to thank my team. These are the people we did this work together. These are my friends, colleagues, like you have colleagues now with whom we started this program 10 years ago. And these are all residents who came along, and most of them then just stayed for a couple of months to help out the local community in Yangon and in Mandalay. I thank you very much for your attention.
Thank you very much, Professor.
Just one thing. Here's my email address. I'm here. If somebody has something he wants to do that has a question, just come to me or write me an email.
Professor Schultz, I loved what you presented. Amazing stuff. As neurosurgeons, we're global thinkers. It's very different than other specialties, okay? So what he's doing is really, we want to contribute. We're not limited by our borders or our city. So this is exactly what we want you to be in the future. Okay, how do you contribute beyond, where you live and give back? Okay, what he's doing here is just amazing. As many of you know, I started the Africa Initiative for children with hydrocephalus as part of the Danish Society. We want you to think of these kind of things where you contribute. We are blamed in neurosurgery for being very arrogant, and that may be true, in many ways. But at the same time, I want you to think there are things bigger than you. Always believe there are things bigger than you. You're not the most important person in the room. That is the future generation of neurosurgeons we want. And Professor Shook is really a great example. So this is just beautiful. Thank you so much.
Thank you.
Professor Short, I would like to add something. This was a beautiful TED Talk kind of presentation, sir. And there was a lot of storytelling, obviously. So just from a student perspective, I think, as I said in the beginning, the things that stick in our minds even a year from now are the anecdotal things, the stories that we hear on these conferences. So obviously every country has its own culture. There might be a radical religious influence on people's perception of medicine as well. So have you encountered these kinds of challenges in doctor-patient communication when in Myanmar? Is there any example that you have in mind that you would like to elaborate on, Professor?
Yeah, I would love to do that. Now, one thing is, we trained a lot of doctors, and we did surgery on hundreds of patients. The vast majority went well. And I say this because I'm proud of it, and also because that's the way it is. But we learn from the bad cases, right? There was this talk about the experienced surgeon being the one with a lot of mistakes, and that's true for everything. So I will share my worst story with you. We went to a place called Miek, which is in the Andaman Sea. It's in the very south, gorgeous place. And there we met a young woman, 22, 2 little children, has a brain tumor. I'm a brain surgeon, so I see a brain tumor, I want to take it out, right? This is what I do. This is my thinking. So there's this patient, and she's like Glasgow 12 or something. Very small community hospital. What do? We find a sterile urine catheter. We put that in as an EVD. She comes up Glasgow 14 or so. So we're very happy, good about that. And then we organize to take her to the capital, to Yangon, to do treatment on her. And we get a plane, we get everything ready, we fly her over, she's finally in Yangon, we schedule surgery for the next day. It was kind of I think it was an intraventricular meningioma actually, but it was a big thing. So we're very happy, and next day we're gonna have this surgery. Next day we come to the hospital, patient's gone. She left the hospital. Well, the story behind this is the family actually took the road while we flew, and they took her again and took her to the village, and there she died a week later. Why did they do that? Because the people in Miek, in southern Myanmar, they're Buddhists, they believe in reincarnation, and they believe that they are being born again where they die. So the worst possible thing for that family was for her to die in the capital because they speak a different language, and then she won't be able to talk to anyone, right? Now, the humbling thing about this experience for us was you have to consider what kind of people you're dealing with. The cultural differences. You might think, we know the world, we know the science, this is all bogus, but that's not the reality of these people. And as Westerners, we always have to think of what cultural context are we working in. And this certainly was, for me, a very humbling experience where we think we know it better, and we actually don't. So that's my story for you.
Thank you, Professor. So next, I would like to just invite Stefan on the stage, our sponsorship chair, because we will continue with the workshops now, and he will tell us how to get there and meet with the companies.
Exactly. My name is Stefan. I'm the. Thank you so much. I'm the chair of the sponsoring and responsible for the financial side of the Congress and responsible for the workshops. Those are next up. We've sent you a list with all of the participants, and there you can see which group you are in at. If you haven't seen the list, we've printed it out and pinned it on the door over there. I will be standing next to the door too. So if you have any questions, I can help you at the beginning. Furthermore, we send out a rotational plan where you can see which each group has planned of. We have 5 workshops, AUN next, then we have MLP. The AUN workshop will be here on the main stage. The online workshops of NextSim and MLP will be in the smaller halls over there. And the workshop of Absurgeon you've probably already seen is where you got your coffee. And the Evanes workshop is upstairs. So you have to go through, where you got the coffee, and then go upstairs so you can find the awareness workshop. Please look into the WhatsApp group. We have put in the plan. If you have any questions or can't find it, either you ask different someone next to you who has the plan. If not, I will be next to the doors. The workshop will be like 20 minutes, so we need to be quick. Thank you.
1, 2.
AUN is a conceptual issue. It's the first time in the history of medicine we created a university. Okay, I'm going to turn this off for a second. Regulations department. She's the chair of that department. Eric is the vice chair. Anna is from Romania. Erica is from Germany, and Grace is our on our board from Bulgaria. Okay. The whole idea is this: why do we need a university for neurosurgery? There are three groups or layers of people that we're trying to work with: medical students, residents, and neurosurgeons. What do we do for medical students? Well, in most medical schools in the United States, for example, you have during your clinical years, you may spend 2 or 3 weeks in neurosurgery. That's it. Then you're trying to make a lifelong decision. You're going to go into neurosurgery after 2 or 3 weeks of rotating and watching somebody do it. No way. I mean, there's no way you understand it or know it, right? What we're creating here for medical students is we're going to have medical students at a level that no medical student ever has been before entering neurosurgery. Probably at level or first or second year resident as far as knowledge is concerned. For the medical students, you do this as part of your medical school and you get a degree, a bachelor degree in neurosurgery, which is a unique degree, but that's what we're doing, okay? For what do you have to do for that? You have to take our academic courses, and the whole program is based on 2 things, academic knowledge and research. You have to get involved in a research project with us in the AUN. These are mostly multi-center, multinational projects, and your name will be in this project as a major publication. That has to happen to be able to graduate. The minimum amount of time is going to be 2 years, but depending how long your medical school is, you could pace it over 3, 4, 5 years. Okay. For residents, as a resident, when I trained, I had neurosurgeons, 5, 6, 7 neurosurgeons. Under these walls, you train for 6, 7 years. Whatever they teach you is what you learn, right? So to develop these silos of knowledge. So we decided we want to have you train in the traditional program and be part of a parallel system, which is this university. No program in the world can have the best of everything in subspecialty in neurosurgery. It just doesn't happen, okay? There's no mathematical way you get that. So you train with your people, but you're part of a university where we have the top experts in the world that are teaching at the same time, but knowledge, understanding, new technologies. So it's a parallel system. So instead of just being in here, you're running 2 parallel systems throughout your residency. A resident will get a master's degree in neurosurgery at the end of that, okay? How about for neurosurgeons who are already finished? We have a PhD in neurosurgery for them. What they have to do, they have to get all the academic, we have core courses, everybody has to pass them for their level. They have to lead a major research project, being a principal investigator with us, and take it all the way, that's the thesis, the PhD thesis. It has to be published in a major journal. So each layer has to be involved in research. Neurosurgery is a very young specialty. You have to learn how to do research. We're going to teach you how to do it. We're going to teach you the whole process from all the way from idea to publication. Every process you're going to learn with us. How do you put idea together, literature search, biostats, the whole thing, okay? So those are the principles in which this is based on. Anna will give you a little bit more details as far as the university program is concerned. So let me first show you, you got the QR code. Let me just show you a very quick video here. The narrator here is Chantel. She's standing back there. She's our president for our Medical Student Club of Ireland, okay? The volume again. Okay. Okay. Yeah, that's how it works. We offer various programs to support. It's state-of-the-art brings the most Okay, so I'm going to start with we're going to do something fun here. We only have a few minutes. I'm going to teach you, I'm going to show you a little example how we teach. We do not teach traditional way in this university. It's not PowerPoint slides and somebody's reading slides. No. We're going to teach you in a very comprehensive way. And we're assuming you know nothing about neurosurgery. So this is really designed for medical students, right? So we do prefer people to have done their, we have a lot of students who want to start their first year of medical school, which is totally fine. We do prefer them having taken neuroanatomy. But beyond that, we're going to take you all the way, okay? So I'm going to just show you a quick case and show you how we will be teaching in this university and for you to understand. And as a fun thing, we're going to do, I'm going to do a little quiz for you that some questions you will answer. Now, some of you, for you where the app is working, use it. Otherwise, use a paper thing, put your name and put your answers on it. We're going to have prizes for the top winners at the gala dinner tomorrow night, okay? Just a fun thing, all right? So if you could do that. So I'm going to start with a case, and I'm going to talk to you a little about it, and then I'm going to ask you some questions based on what I'm telling you, okay? Every question we ask in the AUN, the answer is in the presentation. So there's no weird stuff here, okay? It's all there, all right? It's just for you to figure it out, okay? And that's how we do all the AUN courses and how we're gonna teach you this stuff, right? So I'm gonna go ahead and start with you here. All right, I'm gonna show you a case of an aneurysm, okay, in the brain, all right? This is all, you know, so just I have Corey, who's the head of IT for us and stuff. We're just trying to this is actually beta testing for the big session I'm doing tomorrow morning here at 9. We're just trying to make sure the technology is working as well. Anyway, so as far as this is concerned, so as in medical school, we learn about anatomy of the vessels looking from below, but that's never the anatomy you're looking at as a neurosurgeon coming from the side or whatever. So it's very different. So all I want to do in this session is to transpose your mind in looking at these vessels from a different angle. So that's what I'm trying to achieve in this 5 minutes, okay? So for example, so we have the internal carotid artery. It enters the head here and goes around like this, okay? What I want you to appreciate is as it enters intracranially, it's right next to the optic nerve, which becomes a chiasm. So these are the two optic nerves. Okay, this is optic tract, okay, going backwards, all right? So that's the relationship between the carotid artery and the optic nerve, okay? Now, let's chart moving this into the direction where we're gonna be looking at this from surgery. It will never be that, right? But that's what we see in anatomy books, right? So let's now start moving. Why am I moving this way? Because I'm gonna come at this. I'm gonna come at this from the sylvian fissure. I'm gonna inside this fissure. I'm gonna enter to come down here. So I'm going to keep moving this in that direction to have your mind really look at it from that angle, which is the angle how we will be looking at this, right? So slowly, I'm going to show you how this changes and what you need to know from just this. Okay. What is happening once the carotid enters the head? It's now and it divides into two vessels. One is the middle cerebral artery. The other is the anterior cerebral artery, okay? We call this a bifurcation. And the surgery we're gonna do today is a patient who has an aneurysm sitting right here. This we call a carotid bifurcation aneurysm, just by definition where it is, right? So there's the aneurysm sitting right here. How are we gonna get to that, okay? Of course, we never are looking from below. So we do need to come from above. we need to come we're going to come from here. We're going to go like this inside and come down here. Now we'll come down here. We're going to be looking for the carotid, the middle cerebral artery, anterior cerebral artery. We need to rely on landmarks as we're looking down there to know what's what, and we need to figure that out, right? So that's the idea, all right? So let's go ahead and do this surgery and get down there. And okay. So now, in a realistic way, as a surgeon, I'm standing at the head right here. I'm looking down, okay? So things are a little reversed, right? So our frontal lobe is right here, temporal lobe is right here, okay? So what do we need to do? We need to do a craniotomy like this, and we call this a pterional craniotomy, okay? That opening, why we're doing that is because we have to identify the sylvian fissure that's sitting right here. It's through this sylvian fissure we're going to go down, okay? So that's why we did the craniotomy right there. Now we're going to go down to the carotid and the bifurcation, to the inners, all right? So this is the angle, you know, just want to get you to see that from that perspective, all right? So, okay, so let's to orient you now. We did the craniotomy on the left side, okay? We went down through the sylvian fissure. So this is our temporal lobe. This is our frontal lobe. We just opened this sylvian fissure right here to get down there, okay? So what are we seeing here? So we are seeing this conglomeration of things. Question number one, okay? That either on your thing or write it down, okay? And you cannot change it after we move on because I'm going to tell you the answer. So let's, you know, don't be cheating on me now, all right? So which one is the anterior cerebral artery? A, B, or C, or it's behind this, D? Put that answer first. You know, I showed you the orientation, so I just want to be sure how, if you're thinking about this the right way. Okay, once you're done, we will move. Okay, if you guys are done with that, I'm going to ask question number 2. Okay. So the question number 2 is going to be, where is the optic tract? Is it A? Is it B? Or is it C? Or is behind us and we cannot see it on the left side? Optic tract of the visual pathway. Okay, submit your answers, please. Okay, so I just did this sylvian, I went through the sylvian fissure, okay? And what am I looking at here? So of course we said the carotid artery is here, internal carotid artery, because we're upside down now. That here is the anterior cerebral artery. For all the people who got it right. That is the middle cerebral artery. Of course, it's going to the sylvian fissure, and our aneurysm is sitting here behind us. Okay. And then, as far as the we said the carotid artery has a close relationship with the optic nerve, which is right here. That was a difficult question because that's the optic nerve. Okay. But you cannot see in a very subtle way that the optic nerve ends right here. So that's got to be the chiasm. So this part is the optic tract right there. That was not easy, I have to say. Okay. So that's the anatomy that I want you to start thinking about as we teach you more and more about how to think about these things. All right. Just the style of how we're going to teach this to you. Okay. So anyway, so the surgery is here. In my left, tomorrow I'm gonna, during the 9 a.m. session, I'm gonna show you how to hold the instruments and things like that I'm holding, okay? So in my left hand is a suction here, my right hand is a bipolar, okay? So you have to learn very well to use both hands in a very coordinated fashion, all right? Microsurgery is the heart of neurosurgery. If you're a really good microsurgeon, it just shows how good you are with your hands, okay? So what you're seeing me doing here is that I'm gonna be shrinking this in. See, the traditional technique is, just so you know, if you were to show this case to most neurosurgeons, you see the aneurysm, you put a clip on it, okay? Slowly, we've advanced this technique a little bit. The problem is what happens where complications occur. You see, we saw the big vessels, of course, the carotid, the anterior cerebral artery, and the middle cerebral artery. The problem is there are these tiny vessels that we call the perforators. These perforators supply critical areas of the brain, and they're too small for you. You're not seeing them right now. The problem with these perforators, they are behind the aneurysm coming off this bifurcation, and they're going to areas like the internal capsule and very important areas of the brain. So if I were to do the traditional technique, the standard thing that's done all over the world today, okay, which is go in, I saw the aneurysm, I'll put a clip across the neck of the aneurysm, going all the way down. You're not seeing the perforators behind you, and the clip may obstruct some of these perforators, and you cannot see it. Patient wakes up from surgery, not moving the other side. Wow, what happened? We don't know. Maybe it's a perforator. Well, my whole idea is anticipate what could happen. How can you prevent it? Based on that, I came up with this concept that instead of putting a clip on the aneurysm, let's reshape the aneurysm, make it into a baby aneurysm so we could see behind it before we put the clip, okay? So this is how I do larger aneurysms, what I'm going to show you here. So what you see me doing here, I am just going to change this aneurysm right there. See how I'm shrinking it down to become a baby aneurysm. Now, this technique is difficult. It should only be done in the hands of very experienced patients because, of course, you could rupture the aneurysm, but once you get really good at it, it's a game change, okay, what I'm showing here, okay? It could change the aneurysm completely. You see it's becoming a baby, tiny little aneurysm. What does that do? You see behind me, all these perforators, all these little arteries, there's no way you could have seen those when you put the clip up front. Some of them could be obstructed. Now I could see every one of those tiny vessels. So I'm gonna put the clip in their direct vision. I know the outcome of this patient as I'm doing the surgery. It's not a guess game what happens after surgery, okay? You see, I see everything behind it now. So it's not a blind way of putting a clip on, all right? So that's the idea that, so you see all these tiny arteries now, right? So that's the techniques that we're gonna teach you, okay? See, now we see everything behind us, and now we're putting the clips to finish this. This is now putting clips but I directly see everything. There's no way I can injure anything at this point. There's no guessing game, all right? All right, so that was kind of just a little flavor. We're gonna give you a more detailed thing about how to think about surgery tomorrow morning when we do the presentation, the anatomic presentation. I'm gonna invite Anna, who's the chair of our regulations department, to speak to you. The vice chair is Eric Freund here, okay? And Anna, please.
Yeah, hi. So I would like to present to you some of our most important regulations and the ones that we are mostly asked about. We are, first of all, a non-profit organization and the first neurosurgery university in the world. We are based in the United States, but we are an online university, so it won't interfere with your home university at all, since you can take the courses in your free time. Once you enroll in our university, your courses won't have an expiry date. So you, as we thought, you will take at least two years in order. We offer 3 degrees in the neurosurgery field, and for the pre-medical students, we offer the neuroscience bachelor degree. Since most of us are from Europe, I would like to mention that 1 US credit equals 2 ECTSs. And in order to receive the bachelor degree, you have to accumulate a total of 120 US credits, but we accept up to 90 credits to be transferred from the courses you have already taken. Most probably you transfer the credits from your home medical university. For the master's degree, in order to graduate, you will need a total of 60 US credits, but we can accept up to 50% transferable credits. You will have monthly live sessions with top neurosurgeons, so you will also get interactions during your courses because the other ones are pre-recorded. And your research skills will be the most developed in our university since you will be published in a major journal before you graduate as a requirement. And the most important thing is that you learn about a lot about leadership and its importance, and especially in neurosurgery. These are the most important regulations, but you can find us on social media, Instagram, Facebook, and we also have a website where you can get our contact details. And anytime, anything you would like to ask us, we are there to answer all of your questions. Thank you.
So proud of Anna, Eric, Grace, all of our officers here. This, while senior neurosurgeons are going to be teaching the best in the world of every specialty, subspecialty neurosurgery, this is built and developed by students and residents in neurosurgery all over the world. So it's not a top-down model. It's people who want to know how they want to learn, and then we're going to bring the best to do it. So it's done by you guys to develop this. You know, we're going to give a much more extensive presentation tomorrow morning. The first session in the morning, we're going to really show you a lot as to how we will teach and stuff. But yeah, if you guys can give your paperwork, who's picking that up, Grace? And if you could give those, it's just for fun, and we will get a prize tomorrow night at the gala dinner. We'll have a good time. Now, our officers, all of them are here. You know, INAT, all of them are here. You want questions about the AUN, please ask them. They've all been involved for months working on this. So feel comfortable to ask them any questions that you have. Thank you very much. I think, is this lunchtime? Is that what it is now? What's that? We're done. Okay, so we're gonna do this rehearsal now for our session tomorrow. We're gonna
I need to get the host back, Jason. I can't close it. See, that's another thing I learned. You can't turn the host over without getting it back. Hello, I need to get the host position back. Is anybody there? Oh, okay. Okay.